satisfied. All right. So we now move to the islets of Langerhans. And in the islets, we have the alpha, beta, and delta cells that are part of your islets of Langerhans. And we can start with the alpha cells. The alpha cells produce glucagon. Okay? And glucagon is also produced in some GI cells. So it's not only in the pancreas, you can also have glucagon secretion by some GI cells. And we know that your glucagon basically antagonizes insulin. So whatever insulin does, glucagon does the opposite, which basically means then that we can see glucagon giving you an increase in gluconeogenesis. So you can see an increase in the synthesis of carbohydrates from non-carbohydrate sources. So you see increased gluconeogenesis, you see increase in glycogenolysis. So glycogen is being broken down to glucose. So the plasma level of glucose will go up. Insulin reduces glucose, and so glucagon will increase glucose. And so through that you see an increase in glucose levels. And glucagon also tends to stimulate lipolysis, or what some people call lipolysis. So increased lipolysis. Insulin decreases lipolysis, and so glucagon will increase lipolysis. And because of its effect on plasma glucose levels, glucagon is considered to be one of your counter-regulatory hormones. Anytime your plasma glucose goes below normal, the body tries to bring it back up. And the way the body tries to bring it back up is to increase the secretion of certain hormones. And one of those hormones is glucagon, so that it can bring the glucose back up. Other counter-regulatory hormones will include your growth hormone. Your growth hormone will also try to raise your plasma glucose. Cortisol from the adrenal gland. Cortisol is a counter-regulatory hormone. And then your catecholamines. They are also counter-regulatory hormones can help to bring your glucose back up in case it goes down. So glucagon is a counter-regulatory hormone, and it is available as a drug. You can see it as glycogen. Glycogen is a product that was made from your glucagon. And glycogen, you can administer IVIM or subcutaneously. You just give it about 1 milligram and through one of those routes of administration, and it can help to bring your glucose back up. And so the indication or the use of glucagon or glucagon will simply be hypoglycemia. So whenever you have hypoglycemia, one of the drugs you can use is glycogen, to bring the glucose back up. What is a derivative of your HBP drugs that you can use to elevate plasma glucose? Is there an antihypertensive drug? You've just done hypertension that you can administer orally to bring glucose up? Which one? That is made specifically for hypoglycemia. Which one? What are some examples of your vasodilators? Okay, hydrolysine, and what else? Minoxidil, right? Okay, and what else?
Ace.
This would not be classified as vasodilators. Okay, have you come across this drug?
No.
Okay. I should say, if you have hypertension and you need to reduce it immediately, you use hypostat. Okay, have you come across this drug?
Because
Diazoxide.
no. The drugs.
Okay.
We know about the toxin.
And what about proglycin?
Is this still in the market? And these are all vasodilators?
Okay.
Top 100?
That top 200 is a myth. Don't ever limit yourself to those top 200 or top 300. That's just a way of narrowing down what you should know. Yeah, it's a myth. Okay. Diazoxide is a thiazide that is actually a vasodilator, not a diuretic. And its brand name is Hypostat. This Hypostat you would administer by injection in the given IV because you want to immediately bring blood pressure down. Okay? And another brand name for diazoxide is proglycin. And proglycin you would administer orally. And if you break it down, see, glycemia in favor of. So here's the drug you can administer orally to increase plasma glucose. So it's used to treat hypoglycemia. Okay? So that's what we have for glucagon. And remove alpha.
Well, we have to know the mechanism of action.
Yes, whatever. Okay, for any drug that would take as the representative agent or any drug that is mentioned in class, make it a habit to know at least the other name, that is brand versus generic. And the mechanism of action is a major part of the pharmacology of any drug. And as we go through, we will always look at a group and pick a representative agent of that group. And so its mechanism of action will represent the mechanism of action. Okay. So if we skip over to the delta and then the beta, first let's look at gastrin. So gastrin is a hormone that is produced by the delta cells of your islets, and gastrin can also be produced in the stomach. So it's not just in the pancreas, but also in the stomach. If you look at your stomach, you have two major glands in the stomach. You have one over here, which is called the pyloric gland of the stomach. And you have another one over here that is called the fundic. The fundic gland is also sometimes called the oxyntic gland, but fundic is good. Okay. The cells that produce your hydrochloric acid in the stomach are called Pancreas cells. They're part of your fundic gland. Your fundic gland has the neck cells, the chief cells, and the parietal cells. The parietal cells produce your hydrochloric acid. The pyloric gland here can produce some gastrin. Okay? And being a hormone, by definition, it means it's produced in one part of the body, it gets into the bloodstream, and goes to another part of the body where it induces or causes an effect. So when the pyloric gland produces gastrin, gastrin will travel through the bloodstream to another part of the stomach, the fundic gland, and it will stimulate your parietal cells to produce hydrochloric acid. So that's what gastrin does.
Is parietal inside fundic or?
It's inside fundic.
Okay.
You have your neck cells, you have your chief cells, and you have your parietal cells. Those are the three cells that make up your gland, your fundic gland. Your intrinsic factor, calcium will be produced in the fundic gland. You also have some mucus being produced there, apart from gastrin, pepsinogen can be produced over here. Some of it can also be produced in the fundic gland. Okay, so gastrin that is produced by the pyloric can travel through the bloodstream, stimulate the parietal cells in the fundic gland, and get an increase in hydrochloric acid production. Okay. And so your gastrin is not available by itself as a drug, but a derivative of it that is called pentagastrin is available as a drug. You see that's pentagonal. That's this brand name. And it is considered a secretagogue. So if you have a substance that can cause the secretion of glandular cells, it will be called a secretagogue, something that stimulates the secretion of some organs in the body. So that's what pentagastrin will do, because it's acting just like gastrin. Okay. And so if you have a lot of gastrin being produced, either from the stomach, that is the pyloric gland, or from the delta cells of your islets of Langerhans, you will see an excessive increase in hydrochloric acid. So too much production of gastrin then can lead to peptic ulcer. So that's one of the reasons you can get ulcer. And it can also lead to what is called the Zollinger-Ellison syndrome. So by definition, Zollinger-Ellison syndrome, or what we just call ZE syndrome, is a condition that results from a tumor of your delta cells. Okay? Because the delta cells will produce gastrin, so if you have a tumor, you will have excessive production of gastrin, and that would lead to an excessive production of hydrochloric acid, and that's what gives you your ZE syndrome, Zollinger-Ellison syndrome. Okay. So, like we said, if you have too much hydrochloric acid, you can also get possible peptic ulcer, and you can also get gastritis. Okay. And that is why this drug, pentagastrin or pentabolone, is mainly used for diagnostic purposes. It is mainly used to diagnose ZE syndrome, peptic ulcer, and gastritis. So that's the main indication of that drug. Okay. So that takes care of your gastrin.
Excuse me, sir. Can you please, I'm sorry to take you back, can you please repeat that place you said is gastrin is not available as a drug, but the derivative of it is called
Pentagastrin is the derivative.
So what does it, you say it produces gastrin, right?
No.
What does it do? I didn't
No.
get that point.
It's a secretagogue. It will cause, the HCl to go up of the follic gland. Okay. So now we can look at somatostatin. Somatostatin is of course produced by the delta cells, but it can also be produced in the brain. also produce some somatostatin. And if you look at it, again, in this case, statin, specifically referring to static, that is, it decreases the release from the hypothalamus of your growth hormone. Okay. And it also tends to decrease the release of your thyroid stimulating hormone. All through your endocrine system, you will be seeing examples of homeostasis. You know, an organ produces one thing, that does one thing, and that same organ produces another thing that actually opposes what the other one does. Homeostasis. So somatostatin will decrease growth hormone and decrease your thyroid stimulating hormone released from the hypothalamus. Somatostatin is available as a drug, and you can see it as octreotide. And there are derivatives of octreotide that are also available on the market. We have lanreotide, that's the somatostatin derivative that you can see, and then acereotide is another one. Acereotide can decrease your ACTH level, adrenocorticotropic hormone level. Okay, so if you decrease ACTH, then it means it will be useful in treating what disease? What's the opposite of Addison's disease? What disease do you have when you have a lot of adrenocorticotropic hormone released at the cortex of the adrenal gland?
Hyperthyroidism.
What?
Hyperthyroidism.
It will be what?
No, I was saying that's not what it is.
It's Cushing disease.
Which one?
Cushing disease, how you say it?
Cushing.
Cushing disease.
Okay. Cushing syndrome. Cushing's is like the opposite of Addison's. In Addison's disease, you have decreased, secretions from the adrenal cortex, and in Cushing's is excessive. So if a drug can decrease your ACTH level, then it can be used to manage Cushing's disease. So that's one of the reasons why your acereotide is used for Cushing's syndrome. Okay. Lanreotide okay. I'll put it in question form also. When an individual is growing up and they've reached a maximum height and they're still producing growth hormone, they will do what? They will grow out instead of growing up, right? And what is that condition called? Which one did you say?
Is it dwarfism or?
It's what?
No, that's
Okay.
Is it genetics? Acromegaly.
No, giantism will be growing up.
Giantism is, and the dwarfism is done.
Yeah. For acromegaly, the epiphyses have closed, so you can no longer grow up. And yet you're producing a lot of growth hormone, so you have to grow out.
So what about the people that actually keep growing?
It's
That would be giantism. Yeah.
So what's the disease where, you know, they have like the large faces and what's that?
You know, that could be giantism also.
Oh, that could still be Johnson, okay.
So acromegaly is one of the indications for your lanreotide, you know.
So the lanreotide just, prevents the upper body from growing out more?
Yeah, remember we said that drug, somatostatin, will do what?
Decreases,
Okay,
decreases the growth hormone,
Yeah,
a natural.
exactly. But the one that is used most often is that somatostatin itself. Okay? So somatostatin can be used for many things. We mentioned 3, 4, 5 of them. So one of the indications of somatostatin will be acromegaly. That would be one. Somatostatin can also be used to treat what is called lipomas. Okay. VIP stands for vasoactive intestinal polypeptide. Vasoactive intestinal polypeptides. And when you have a tumor of the cells that produce that, those VIPs, you can use your somatostatin to manage that.
So when you say the one you wanna use, you're pointing to the octreotide or all of the derivatives in general?
This is somatostatin in particular that you can use for these things that I'm listed.
Okay, but you pointed to the octreotide when you said that, right?
Yeah, octreotide is somatostatin.
Correct.
Right.
But what I guess my question was, there were other derivatives, do they treat it as well or just?
No,
The octreotide?
it's just octreotide.
Okay.
Yeah. Okay. You can get some bleeding in the esophagus. It's called esophageal. Okay, esophageal varicose bleeding. The octreotide can stop that bleeding, so it's very.
Sorry, sir, now I'm kind of confused, so are you saying the octreotide is also the indication for those 3?
Now, octreotide is a brand name for somatostatin,
And somatostatin is the
and
indication?
it's used in all of this that we listed.
Okay.
Lanreotide and octreotide are derivatives of somatostatin or your octreotide, but they are not, for instance, used in lipomas.
So they have their specific
Or-
indication?
Yeah, which we mentioned,
Yes.
you know.
But did we mention anything for the octreotide?
That's what we're listing for octreotide.
Okay, so octreotide is the indication for those 3?
We'll still continue.
Oh, okay.
Okay, so octreotide can be used for this. It can be used for managing dumping syndrome. Dumping syndrome is a condition that you see when you use surgical methods to treat severe peptic ulcer. If you use surgery to treat peptic ulcer, 20 minutes after that patient eats anything that has carbohydrates in it, they would experience things that would look like injection of histamine. They will get vasodilation, they will get itching, their blood pressure will drop, they will be sweating, things like that. And it's called dumping syndrome. And one way of managing dumping syndrome is to give your octreotide. Carcinoid tumor or carcinoid syndrome is also treated with octreotide. If it's at the syndrome level and it's not yet cancerous, okay, you can use octreotide. Because you can have carcinoid syndrome and you can have carcinoid tumor. Carcinoid syndrome is a situation in which you have a lot of serotonin being produced in the GI tract. There are some cells called enterochromaffin cells that produce a lot of serotonin in your GI tract. Okay? And so when you have a tumor of those enterochromaffin cells, you get your carcinoid syndrome. And the outstanding characteristic of carcinoid tumor or carcinoid syndrome is torrential diarrhea. It will be massive, okay, because of all that serotonin. And so one of the drugs you use there is octreotide.
So the tumor leads to the syndrome.
Our syndrome is.
No, the syndrome will be a selection of symptoms.
Oh, okay.
Right. You know, you can have a tumor that is not malignant. Okay. So, but once it gets malignant, you have to use an anti-cancer drug to treat carcinoid tumor.
Can I ask a question? So if it's producing a lot of serotonin and maybe, for example, somebody's on an SSRI, is that something you would have to take note of in terms of would that be or any type of drug that does have serotonin in it or increases the serotonin syndrome, would that be an issue for somebody who's experiencing that kind of thing?
If somebody is at risk of serotonin syndrome, they should never touch that drug. Because it will reduce the effects of serotonin. Okay? So in this condition, you have a lot of serotonin being produced.
Mm-hmm.
But remember, it's within the GI tract, not central.
Okay, so it can.
Okay.
So,
Then you have AIDS-related diarrhea, okay, that will also respond to octreotide, treatment. So you see, octreotide can be used in many conditions.
So how does the annuated syndrome relate to?
It's the same thing because here we're talking about in the GI, right? And so you have all those 5-HT, that is serotonin causing all that diarrhea. Okay. So that's for your somatostatin.
that number 6, was that 8?
It's
AIDS
related,
related diarrhea.
it's related,
You got your question answered? Okay.
Thank you.
And then we have one that is called ghrelin. And if you look in that name, basically you will see what it does, right? What is that? Growth hormone. Okay, and what is that? Release. So it's a growth hormone releasing hormone, basically. Okay, so that's what mentioned homeostasis. The same delta cells of islets of Langerhans in that organ producing somatostatin, which decreases growth hormone, is also producing ghrelin, which increases growth hormone. Balance. The body likes balance.
So Sonata is
So green,
increasing, ghrelin is increasing.
Exactly. Growth hormone is actually available as a drug called somatropin. A derivative of somatropin that's available on the market is norditropin. So, as we can tell, then your ghrelin will increase growth hormone production from release from the anterior pituitary gland. So it increases the secretion of your growth hormone from the anterior pituitary. The reason I put epsilon here is that if you're talking broadly, you can say that yes, ghrelin is produced by the delta cells, but actually there are some specific cells that produce ghrelin, and those are your epsilon cells.
Where are they located?
Right here, also in the islets of Langerhans where your delta cells are. So it's like within the delta cells, you have a population that produces specifically ghrelin, and those are your epsilon cells. Okay. Now, apart from the epsilon cells, or apart from your islets of Langerhans, ghrelin can also be produced from the GI tract. Okay. And in the stomach, you have some cells that are called PD-1 cells. PD-1. PD-1 cells are housed in the stomach and they produce ghrelin. And the effect has to do with your appetite. Okay. So if we look at what ghrelin does, in terms of functions, ghrelin would increase growth hormone. Ghrelin will also increase your appetite. Increase, I guess, if your appetite is increased, you will grow.
Which direction?
Yeah.
So it increases appetite.
So that's just from the ghrelin from the stomach.
No, anytime you have ghrelin in the bloodstream, it can, yeah, it can do that. Now, insulin sensitivity, and I can put insulin resistance, can also be controlled by ghrelin. If you can reduce insulin resistance, you can get a positive effect on a diabetic patient. Okay. In other words, if I decrease insulin resistance, that can give me an increase in insulin sensitivity. In a diabetic patient, that's what you want, insulin sensitivity. You want it to go up. That would mean that more insulin can be internalized, and it can be produced, and then it would internalize the glucose into cells, so your plasma glucose will drop. That's what you want in a diabetic patient. The greater your concentration of ghrelin, the less your insulin resistance. So if you increase ghrelin production, you will see a drop in insulin resistance. So that suggests then that ghrelin should be beneficial to a diabetic patient. Okay? You increase ghrelin, you get a decrease in resistance, that is insulin resistance, which will lead to an increase in insulin sensitivity. So insulin is better able to internalize glucose, so your plasma glucose falls. And that's what you want in a diabetic patient. Okay?
Is it used for the exenatide? Is it related to exenatide?
Is it used for what?
The exenatide that reduces hyperglycemia.
Okay, that's, we'll get to that in a second. We're talking about creatinine. Yeah, creatinine. Okay. So, the issue then is, what does ghrelin really do? We know that it produces, of course, an increase in growth hormone. So is it possible then that that growth hormone by itself is what is actually giving you a decrease in insulin resistance? Okay. And that is why this drug, norditropin, is now being investigated for clinical usage in type 2 diabetes. Okay. Remember, norditropin is an analog of growth hormone. The ghrelin will increase growth hormone, and when you get ghrelin, or if you produce more ghrelin, you get a decrease in insulin resistance, which will lead to an increase in insulin sensitivity, which will lead to more internalization of glucose, and then a drop in plasma glucose. Then maybe a growth hormone derivative should or would help a type 2 diabetic patient. So that's why that norditropin is currently being investigated for use in type 2.
So what stimulates ghrelin to be released?
Why is what?
So what stimulates ghrelin to be released?
Say that again?
What stimulates ghrelin to be released to cause this?
What will make ghrelin to be released? Well, if you can stimulate your delta cells, if you have reduced growth, the body will respond by producing more ghrelin. Okay, so that's how ghrelin can help.
So if delta cells are deficient, ghrelin is inhibited, therefore the insulin sensitivity increases and goes in the opposite direction.
Okay. What would be a medical terminology for a drug that increases appetite? What word would you use? Okay. What if I say this? Orexigenic. What's the word you will use if you say somebody does not have appetite? Anorexic. Okay. See? And
Maybe that's.
orexia.
Oh.
Okay. All right. There's a hormone that's produced in the body that's called leptin. Leptin is an anorexigenic. Okay. Ghrelin is an orexigenic. So ghrelin increases appetite, leptin decreases appetite. So if somebody is obese, would you say they have high levels of leptin or low levels?
Low levels.
Aha.
What?
That's why nature has all that
Like
rebound.
feedback.
Exactly, rebound mechanism. Would you believe in obese patients, they actually have very high levels of leptin.
It's it's not working.
Okay? Very high levels of leptin. So that's one of the areas being looked at now for management of severe obesity. You know, and the reason is because if the person is obese, right? The body is saying you're eating too much. And so I should produce something that will reduce your appetite. Right? Mm-hmm. And what will reduce your appetite? An anorexigenic. Mm-hmm. And that is leptin. Yeah. So you have high levels of leptin in people that are severely obese. Those are anorexigenic. Okay. Now we go to the last cells. That will be your beta cells. For the beta cells, you have amylin, and then of course you have insulin being produced. Amylin is secreted along with your insulin, you know, when you stimulate your beta cells of the islets of Langerhans. And we know that amylin is available as a drug. Said, Simlin. We no longer have Simlin vials, but the pre-filled pens are still available. So we have amylin, and we know where it would come from the beta cells of the islets of Langerhans. So what does amylin do? One, amylin will decrease glucagon production. Decrease glucagon production. So you see homeostasis there also. Something that is produced by the beta cells is decreasing something that is produced by the alpha cells in the same organ. Balance. And your amylin would also decrease gastric emptying. And again, that would mean it increases gastric emptying time. And it will tend to increase hydrochloric acid production in the stomach. And then it tends to decrease appetite. So basically, leading to satiety. Okay. So that's what amylin does in terms of its actions, pharmacological actions. The drug can be used to treat both or to manage both type 1 and type 2.
So if you're decreasing appetite, it's because, so I'm feeling full, or that my appetite is just decreased, I'm not hungry?
If you are decreasing appetite, you are not seem like you are full. And if you look at what it does over here also, it creates gastric empty. If your stomach is full, you don't feel like eating, you feel satisfied. So amylin can be used to treat types 1 and 2. In type 1, you usually start with 15 micrograms, and that will be administered subcutaneously daily. And you always give it immediately prior to one of the main meals of the day. And then you can titrate it. After about 1 month, you can titrate it up to 30 micrograms a day, subcutaneously. In your type 2, the initial dosage is usually around 60 micrograms. And that can be titrated up to 120 micrograms. And again, it will be given immediately before a main meal of the day.
So amylin is the drug itself?
Yeah, remember, amylin is what is produced by the beta cells, and it's been formulated into a drug, simply. Right. And so we know what it does, we know its dosage and indications. What are some of the adverse effects you can see with amylin? It can give you headaches, it can give you nausea and vomiting, and it can give you anorexia.
Since there was an increase in hydrochloric HCl, can it also here put you at risk for ulcer?
Can it do what you
Can
say?
it put you at risk for an ulcer?
No, it doesn't increase it to that level.
Oh, it doesn't go.
So, that's what the major signs are, and to some extent, you can give it dyspepsia. Yeah, you give it dyspepsia. Those are the adverse effects of your Simlin, which is the drug derivative of your amylin.
Which is under the
Yeah. And all things being considered, those are not major. If you're looking at adverse effects of drugs. So essentially we say that amylin is relatively safe. Okay? The only problem is that it does not give you a very good A1C reduction. It only gives you a 0.33% drop in your A1C. That's not very good. And that's why you don't see it used prominently, because you have drugs that can give you close to 1 or 1.5 or 2 and all. So that's what we have for your amylin. If you want to, you can put a little column in your notes where you can put together the A1C drop that you will get with different anti-diabetic drugs. So you can see at a glance, how effective these drugs are.
I think even the ones that you talk about with the delta cells and all those, how they
those are not used specifically for diabetes. We're getting more now into the drugs that you use to. Yes. Now, before we get to the last thing there, which was insulin, right? Because insulin was the last hormone that we listed on the islands of Lancaster. Let's mention something that is called IPS, just for cautionary purposes. And then we'll mention incretins. Remember when we said that glucagon can be used to treat hypoglycemia because it will bring the blood sugar back home. You have to be sure that that is a real hypoglycemic condition. When somebody's blood pressure and blood sugar drops, let me first state this. That's a normal glucose level, 80 to 120 milligrams per deciliter. If somebody is hyperglycemic, let's just pick a figure. Let's say they have 400 milligrams per deciliter. The fact that you have a drop in plasma glucose does not mean you have hypoglycemia. A patient comes in with 400. I can give a drug that will lower this, right, to, let's say, 130 milligrams per deciliter. That patient does not have hypoglycemia. Okay? Because this is normal. You're just bringing their high levels down towards normal. That's not hypoglycemia. That does not mean that this drug is causing hypoglycemia. But if this drug can continue to drop that plasma glucose down to say like 50 milligrams per deciliter, then it is producing hypoglycemia. Okay? So we got that concept. Okay? Because a drug drops or reduces plasma glucose does not mean the drug is a hypoglycemic agent. It can just be reducing high levels down towards normal. But let's say the drug causes hypoglycemia. Or let's say somebody overshoots on their insulin. Or maybe somebody took the right dosage of insulin, but then they went jogging. All those things can make your blood glucose fall below normal. So you can get into hypoglycemia. And what are the signs that you know that you would exhibit? If the blood pressure, blood sugar drops way below normal. Dizziness. Shakiness. What else? Anxiety. Palpitation. Increase in heart rate. You know, tachycardia and all that. Right. Confusion. You know. So if they're exhibiting all those things, So normally you would say, oh, grab a Snicker bar, you know, a bar of Snickers or
Orange juice?
Orange juice.
orange juice or what have you. Okay. So those would be two hypoglycemic conditions. That's a situation in which you can inject glucagon and make the plasma glucose go back up to normal. Okay. But there is a particular condition that is called idiopathic postprandial syndrome. Idiopathic postprandial, that is after eating, syndrome. It occurs within 2 to 4 hours after eating. The patient would actually exhibit those signs and symptoms that we talked about of hypoglycemia. But if you take their blood levels of sugar, it is actually normal. See? So they're exhibiting signs and symptoms of hypoglycemia, but they don't have true hypoglycemia. So in that kind of situation, no, don't use all those things we mentioned, you know, glucagon and bar of Snickers and all that. So you basically control their carbohydrate intake. That's how one would do that. So IPS should always be distinguished from your true hypoglycemia. That's one thing we wanted to clear up here.
So if you're experiencing that, what do you do when you experience IPS?
When you're experiencing IPS, you either, if they're still eating any carbohydrate or anything, you decrease that carbohydrate level that they're ingesting. You can manage the anxiety, if you will. If you have some anti-anxiety drugs, you give them Valium, right? They go to sleep while working in the pharmacy. No. No, but you can manage anxiety, you can reduce the tachycardia, you know. So you just do palliative treatment in that condition. IPS is also sometimes called reactive hypoglycemia. That's another name for IPS. However, we have something in the body that tends to help us control sugar level. So you eat. The moment you eat, especially if you eat a carbohydrate food or what have you, in the GI tract, the body will produce two hormones. GLP and GIP. Okay. GLP means glucagon-like. Glucagon-like polypeptide. And your GLP is insulinotropic. Polypeptide, that is glucose-driven or glucose-derived insulinotropic peptide. These two peptides that are released in the GI tract in response to food, okay? These two, that is the GLP and GIP, they will then go into the bloodstream and they will travel to your beta cells of Langerhans, and they will increase the sensitivity of your beta cells to glucose. And so the beta cells will now increase production of insulin. That's why when you eat, if you measure your insulin level, it should go up because the body will try to, because initially when you eat, within 2 hours, your sugar level can go up. Okay, and so it needs to be balanced, needs to be managed, and that's what will happen. Yeah. And so GLP and GIP are two hormones that help us to control sugar levels and insulin levels, and thereby control sugar levels. They're released in response to food ingestion. Now, the unfortunate thing is that no sooner are they released than they are broken up, that is metabolized, by dipeptidyl peptidase form, DPP form, dipeptidyl peptidase. So this enzyme metabolizes your GLP and GIP rapidly. So if you're looking, or if you're thinking about a diabetic patient,
Is this where the septic gluten and all this gluten?
we're leading into that. So if you understand the background, then it will be easy to understand the drugs.
Okay.
Okay? So when you say gliptins, that's where that glip comes from. Glip. That is something that behaves like your GLP-1. And the only reason it will behave like your GLP-1 is because it will inhibit the enzyme that metabolizes your GLP. But that will come under your oral drugs when we get to the oral drugs. Okay. So right now, you eat in the GI tract, GLP and GIP will be produced. They will go to the bloodstream, go to the beta cells, sensitize the beta cells to the amount of glucose that you have in your bloodstream, and then the beta cells will produce an adequate amount of insulin so that you can lower your blood glucose up to normal. And GLP and GIP, both of them are referred to as incretins. Those are your incretins. So in a diabetic patient, of course, you will prefer for them to have a lot of incretins, because the incretins will eventually cause more insulin, so blood glucose can go down. Okay. So how do I get more incretins? It will be one of two ways. Number one, I can develop a drug that would work as an agonist. Okay? That would work as an agonist at the receptor sites of my incretins. So in other words, I could develop a drug that will behave just like the incretins, because it will stimulate the same receptor that the incretins stimulate. So those are usually called incretinomimetic agents. So they mimic the actions of incretins at the receptor site. So that's one thing I can do. The other thing I could do is inhibit this enzyme, dipeptidyl peptidase 4. If I inhibit this enzyme, there's nothing to break down GLP and GIP. So GLP and GIP will be more available to go to the beta cells. Okay, so I can stimulate the receptor, or I can inhibit the enzyme that inhibits the incretins. That way, I can get more incretin action. So, the agents that will act as an agonist at the receptor sites, then the so-called incretinomimetics, and one incretinomimetic is your bieta. And that's your exenatide. And you have a durable form of bieta, that is a durable form of exenatide, that is called biduria. So it's like a long-acting form of your bieta. So these two contain the same thing, exenatide. And you see right here, the durable bieta, biduria. So you have another one, which is lixisenatide. So all of these are incretinomimetics. The incretinomimetics that work as an agonist at the incretin receptors. So which means that they're still susceptible to metabolism by your DPP4. Okay? So those are incretinomimetics that are agonists and that are susceptible to DPP4 actions. And then you have another class of incretinomimetics that can work at the incretin receptors, but that are more resistant to DPP4 actions. Okay? And that's where you have your liraglutide. Those are the glutides. Glutide. You have form of semaglutide. Glutide. So this liraglutide group will be more resistant to destruction by DPP4. So they're also incretinomimetics.
Are you saying DPP4 cannot metabolize those drugs?
Right, they're more resistant to metabolism by DPP4.
What's
And-
in
and
them
why-
that's so special? I said, what is in them that are so special compared to the?
If you give me a fraction of a second.
Our brains are just racing.
That's what I just got to saying. Why are they resistant? It's because of two reasons. One, the they have a fatty acid at position 26 in their structure, which protects them from DPP4 activity. And two, they congregate when you administer them. It's like a micellar congregation, and that protects them from DPP4. So those two reasons is
Can you
why
repeat the
they
second
are.
reason, please?
Huh?
Can you please repeat the second reason?
When you administer this four right here, they will form like a micellar formulation or congregation. It's like almost like plotting, so that DPP4 cannot break through that defensive mechanism, if you will. So micellar congregation, and then the presence of a fatty acid at the 26th position. Those are the two reasons why your liraglutide will be more resistant to destruction by DPP4. I will just take the last 5 minutes so we can go, and then we'll start off from there next time. Let's just look at incretins in general, all the so-called incretinomimetics. Physiologically, what do? Number one, they increase insulin levels based on plasma levels of glucose. That is basically what we described here. Yeah. It can give you an increase in insulin, based on dietary ingestion of food, of glucose. Two, they would increase hydrochloric acid production, just like amylin. Three, just like amylin, they would decrease gastric emptying. And I can use the word kind, right? Yeah. Nice. And four, of course, they would decrease appetite. The decrease in appetite caused by incretinomimetics is sometimes so strong that the patient will start losing weight. So weight loss can result from therapy with incretinomimetics. And you do have some that are actually formulated just for weight reduction. And there's a formulation of liraglutide called Saxenda that is just for weight reduction. There's a formulation of semaglutide that's called Wegovy, that is also just for weight reduction. Yes?
So, it's eating helps the body increase the production of insulin. Is it really a good thing that these drugs increase the appetite?
Yes, it's a good thing, because usually if you look at many diabetic patients, they're overweight. So one of your goals actually is to decrease weight.
So, will it be like one of those things where eventually your body is gonna stop making insulin because it's recognizing that you're getting it from an outside source?
No, the body would only stop making this. Remember, this is postprandial. Okay?
So this is
So these things are responding to ingestion of food.
okay.
The incretins is not your regular day-to-day normal production of insulin.
Okay.
Yeah, these are food derived or diet derived. Is when you eat that this GLP and GLP-1 will be released.
Okay.
Yeah. So,
Semaglutide, did you say
Those
you
are gastro.
Decrease of estrogen.
the Revlotide and semaglutide, yeah, those ones have specific formulations that are used for weight loss. But we'll describe those, we'll describe Saxenda and we'll describe, Wegovy. Yeah, when we get there.
So, I'm confused. So if you're saying all this happens naturally after you eat, what are the purpose of these drugs then if you're gonna get them after you eat? Like, postprandial?
Yeah, I mean, postprandial, you would say, when we talk about GLP-1 and your gait, those are just normal control of normal glucose, So if you want to keep reducing that plasma glucose, remember the diabetic patient already has abnormal levels of glucose. So if you have abnormal levels of glucose, you want to produce a high level of insulin to bring that abnormal level down. Whether the diabetic patient eats or not, their plasma glucose is still high. Yeah. So that's why you want to prevent the metabolism of those incretins so they can stick around long enough to go to the beta cells and stimulate the beta cells to produce insulin. Yeah.
So these drugs, it's not like it's mimicking specifically GLP or GI, it's just incretins in general.
Those are your incretins. You just want to keep them alive. You don't want them to be destroyed by DPP-4. And remember, we said they are agonists. So these drugs can actually go to the receptor where your GIP and GLP work and stimulate that receptor and produce that same effect. Yeah.
And GLP is still hanging around doing this thing.
Your normal production, yes. So just very quickly, exenatide or Byetta, we know is anti-incretinomimetic. We've seen what it would do physiologically. Okay, in terms of indications, your incretinomimetics are only used for type 1 diabetes. They're not effective against type 2, and they're not effective in DKA, or diabetic ketoacidosis. So unlike amylin, which was effective in both types 1 and 2, incretinomimetics are just effective in type 1. Okay, so that's one thing. So that's what Byetta will do for you. Byetta, you can give 5 micrograms subcutaneously on a BID basis, and then you can titrate that up to 10 micrograms on a BID basis. Okay. Bydureon, because it's durable, it's a long-acting one, you can use 2 milligrams. Well, that's per week. Okay, 2 milligrams on a weekly basis, given subcutaneously, and it can help to manage your type 2. Lexosenatide, you give 10 milligrams, 10 micrograms of that. It's 5 micrograms, so going all the way to about 10 micrograms. That's on a BID basis. So lexosenatide, about 10 micrograms can be administered. And lexosenatide is sometimes combined with insulin. Okay, like your insulin glargine. So lexacenatide plus your insulin glargine is what you have in this combination drug. Solid form. You know.
But then just try to apply the sensor and the burger.
Yeah, combination, it's a combination drug. Of insulin glargine and lexacenatide.
We're looking at your handout, that's on Blackboard, and it says these, encrypted, genetics are used in type 2 diabetes.
That's what I was wondering.
Yeah.
Yeah, type 2.
Oh.
Oh, you said type 1.
Oh.
That's what
No, it's only type 2, not.
So can we do a repeat, okay, so what one is for type 1, which one is for type 2, so we won't get confused?
Your sibling is for 1 and 2. The incretin are only used in type 2. Okay. Yeah, so, the solid is a combination drug, like we said. And the adverse effects that you will see with your incretin will be very similar to the adverse effects that you see with your sibling. Okay, the nausea, vomiting, in this case diarrhea, you know, so nausea, vomiting, diarrhea, they can produce some dizziness, and they can produce some headaches.
Are they doing anorexia too? Is it producing anorexia effects too?
Yeah, they can all cause weight loss because of the reduced appetite. Okay. Now, for this group, the liraglutide group that is more resistant, those can actually affect the thyroid. You know, so they can cause a thyroid tumor, or what is called medullary thyroid cancer, MTC, medullary thyroid cancer. Now, that is more in animals. Okay. It has not really been demonstrated in humans. But if a human being has signs and symptoms of some dysfunction of the thyroid, then you don't want to use this liraglutide group. Okay. And then hives or urticaria. Urticaria can also be an adverse effect of those groups. The incretin in general will give you about a 0.7 to 0.9% A1 reduction, A1C. And the next time when we look at the liraglutide group, we'll mention some specific percentage of A1C reduction.
So what are the signs and symptoms of MTC? What are the signs and symptoms of MTC, just so we know that, okay, if the human is experiencing it?
You have difficulty in breathing, you will have difficulty in swallowing. Exactly. So, yeah, so showing signs of that, and if it's a tumor, then you will see things that will look like hyperthyroidism. You know, so they will be restless, they will be jittery, they will be tearing their hair, also thinning hair will be part of that. You can also see a difference in the aperture of the eyes. Okay. So all those things can be seen, but the one that will demonstrate immediately, yes, will be things that have to do with ingestion of foods.
Excuse me, sir. How much percent decrease in A1C for this group?
Incretin in general, you see about 0.7 to about 0.9, percent reduction. But the liraglutide group actually goes higher than that. So for instance, you might as well mention, For instance, semaglutide can give you a 1.5% reduction in A1C. The liraglutide can give you like the 1.1% reduction in A1C levels. And
Are they
liraglutide,
used by themselves, or are they used like with metformin? You know, since they have such a low percentage?
if they're in combination with something else, we'll mention that.
Mhm.
You know, I'm just talking about by themselves. For instance, if you give Trulicity, you know, Trulicity is the one that will give you 1.1% reduction in A1C. You know, if you give Ozempic, it will give you 1.5% reduction in A1C. Albuterol will give you precisely 0.78% reduction in A1C. And liraglutide has a range. Liraglutide can give you between 0.7 and 0.9, just like what you would expect for retinal-magnetic.
Did you explain, how often linaclotide is administered? Like, is it daily?
Which one?
The lexatinib?
Yeah, we'll be discussing this group next time. But, you know, oh, which one? Lexatinib, yeah, David. Okay.
And you want to see of all of them?
A1C what?
And you want us to know the A1C reduction of all of them?
That's how you know the effectiveness of which one versus which one, right?
Yes.
Okay.
But as a physician, how are you gonna know which one you wanna recommend for your patient? Is it based on A1C reduction, or, you know, based on mechanism of action?
That's one of the major considerations.
Okay.
You have other considerations. You know, tolerability will be one. Route of administration will be one. The reduction in the risk of cardiovascular problems will be another. And that's why you see semaglutide getting a lot of favor, because
It's an oral drug.
it gives you a significant reduction in cardiovascular risk. So, but you have to consider the weight reduction. You don't start somebody off with semaglutide unless if you want them to change their wardrobe.
Would it be beneficial?
Would it be what?
Would it be beneficial, like?
If
Because
you're
I do.
If you have the money to change your wardrobe. Yeah, but you don't usually see semaglutide as a starting point. Let's put it that, because it causes drastic drop in weight. You know, but it's excellent in terms of cardiovascular risk, and it produces the highest A1C reduction at 1.5. And then also the route of administration is one that you can give orally as well as by injection. So, questions?
So tomorrow, what do you want us to prepare for? Just review
Whatever your handout says in the so basically from here, tomorrow we'll just start with this group. And we've even already mentioned most of the things. But we'll just briefly mention those, look at some of the combinations, look at some of the dosages that you will use for weight reduction, you know. And then we'll move on to insulin, because that will be the last thing left on the injectables. And after that, we'll go to the oral, that is your oral hypoglycemic agents. That's where you have all these metformins and sulfonylurea,